Hello everyone, welcome to another episode in My Spine World. The topic of today's discussion is tuberculosis, specifically tuberculosis of spine, also known as Pott's disease. Tuberculosis or TB is caused by Mycobacterium tuberculosis. It is a specific acid-fast bacilli with characteristic giant cell formation in the tissues. TB occurs in every part of the world. In 2020, the largest number of new TB cases occurred in the WHO Southeast Asian region, with 43% of new cases, followed by the WHO African region with 25% of new cases, and the WHO Western Pacific with 18%. In 2020, 86% of the new TB cases occurred in the 30 high TB burden countries. 8 countries accounted for 2/3 of these new TB cases. They include India, China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. A total of 1.5 million people died from TB in 2020. TB is the 13th leading cause of death and the second leading infectious killer after COVID-19. The last few decades saw a resurgence of tuberculosis in both the developing and the developed world. Increased incidence of co-infection with HIV, multi-drug resistance, and global migration were a few of the key reasons why we saw a resurgence of tuberculosis. And ending the TB epidemic by 2030 is among the health targets of the United Nations Sustainable Development Goals, or SDG. Tuberculosis of spine, also known as Pott's disease, was described by the famous British surgeon Percival Pott in the late 18th century. He recognized it as a condition of the spine causing deformity as well as neurological deficits, and majority of his patients were infants and young children. Even though tuberculosis is mainly a pulmonary pathology, the pathogen can spread hematogenously to various extrapulmonary locations. This includes the central nervous system, the lymphatics, pleura. It can be a disseminated or miliary tuberculosis. It can seep into various bones and joints, including the spine, and also the genitourinary tract. Of the extrapulmonary tuberculosis, 1 to 3% of them have tuberculosis of the spine and the skeletal system. Of the skeletal TB, 50% occurs as spinal tuberculosis. Of the spinal tuberculosis, 50% occurs in the thoracic spine. Half of it, 25%, occurs in the cervical, and the other 25% in the lumbar spine. Pelvis, hip, knee, ribs, ankle, elbow, and various other multiple sites accounts for the rest. Tuberculosis of the skeletal system occurs through a hematogenous spread. It's always secondary to a lung or abdominal involvement. In the spine, usually 2 continuous vertebrae are involved. Skip lesions are possible. Also possible are solitary lesions. Skip lesions account for almost 4 to 10% of the cases. Hence, it's important to look for another lesion if you find one in a particular region of the spine. When we talk about the involvement of tuberculosis with regards to the spine, various patterns of vertebral involvement can be seen, mainly 4 patterns, the commonest being the paradiscal, then comes the central, then the anterior, and then the last is the appendiceal. The paradiscal pattern is the most common entity. It occurs adjacent to the intervertebral disc, leading to narrowing of the disc space, as shown in the MRI. There is destruction of the subchondral bone with subsequent herniation of the disc into the vertebral body, or even by direct involvement of the disc. An MRI imaging shows a low signal on T1 weighted images and high on T2 weighted images in the end plate, narrowing of the disc, and large paraspinal and sometimes even epidural abscesses. This MRI image shows the paradiscal abscess which is present around here, and you can also see the psoas abscess causing the psoas to swell up on this particular side of the vertebrae. and also the axial cut shows the epidural abscess that is present. Whereas the anterior type occurs in the as a subperiosteal lesion under the anterior longitudinal ligament, or the ALL. Pus spreads over multiple vertebral segments. It strips the periosteum and the ALL from anterior surface of the vertebral bodies. Periosteal stripping renders the vertebrae avascular and susceptible to more infection or secondary infections. Both pressure and ischemia combine to produce anterior scalloping of the vertebrae. Because it spreads anteriorly under the anterior longitudinal ligament, collapse of the vertebral body and diminution of the disc space is usually minimal and it occurs very, very late. It is more common in the thoracic spine and in children, and the MRI imaging shows subligamentous abscesses, preservation of the disc, an abnormal signal involving multiple vertebral segments, representing the vertebral tuberculosis osteomyelitis. Whereas the central lesions are centered on the vertebral body, it is spread or seeded through Batten's venous plexus or posterior vertebral artery, and hence the central location. Disc is generally not involved, and vertebral collapse occur quite early, resulting in vertebral planar appearance. MRI signal abnormality of the vertebral body with preservation of the disc is seen. Because of the particular appearance of the central lesion, it is indistinguishable from that of lymphoma or metastasis. Whereas the appendiceal lesions are uncommon lesions which occurs in less than 5%. It can produce isolated pedicles and laminae lesions, transverse processes, and sometimes spinous process lesions. It can also occur in conjunction with typical paradiscal variant, and radiographically it produces erosive lesions, paravertebral shadows with intact disc space, and hence even sometimes indistinguishable from a lytic or from a tumorous lesion. Rarely it can present a synovitis of the facet joints even. When you look at the natural course of tuberculosis, of skeletal tuberculosis, it usually goes through 3 stages: stage of onset, stage of destruction, stage of repair, and ankylosis. Stage of onset is usually last maybe from 1 month to up to even 1 year. Depends on how good the immunity of the individual is. It's usually a localized disease. You can have warm tender joints or swellings, localized osteoporosis, and minimal destruction of the bone. Whereas the stage of destruction lasts from around 1 to 3 years. It is a disease of progression. There is gross bony destruction. There is deformity, there is subluxation, there is contractures and abscess formation. Abscesses rupture, forming sinuses and causing bacterial superinfection. In spine, this is a stage which causes instability and neurological compromise. And the last stage in the natural course is the stage of repair and ankylosis. It can extend anywhere from 2 or 3 years. Abscesses resorb, sinuses heal, bones remineralize, and joints, or even in the spine, causes bony ankylosis or fibrous ankylosis. It depends on if there is a pyogenic superinfection. Of all the complications of tuberculosis, paraplegia obviously is the most devastating complication. Sutton has classified tuberculous paraplegia into 2 main types: early and late. Early onset paraplegia is a paraplegia that is associated with active disease. It occurs within the first 2 years of onset. And the pathology that causes paraplegia is inflammatory edema, granulation tissue abscesses, caseous material, and sometimes ischemia of the cord. And the prognosis of early onset paraplegia is good. Whereas late onset paraplegia is associated with heel disease, and this occurs after 2 years of onset of the disease. It's usually because of a recrudescence of the disease or due to mechanical pressure on the cord. And the pathology is usually because of a sequestral debris or internal gibbous or stenosis of the canal, and the prognosis is poor. Neurologic involvement in TB spine is either because of a cord compression, instability, intrinsic causes, or an endarteritis, or a vascular cause. Kumar has classified paraplegia or tetraplegia of TB spine into 4 main stages: from negligible to severe. The higher the grave, the prognosis is. Now let's look at what are the key elements that you look out for in clinical examination of the spine in tuberculosis. It could be localized tenderness along the vertebrae, soft tissue swelling, indicating it could be a cold abscess, severe paravertebral muscle spasm, various deformities, kyphotic, scoliotic, due to collapse and wedging of the vertebral bodies, and varying degrees of weakness, either of the upper or the lower limbs. Cold abscesses are caused by tuberculous necrotic material. From the dorsolumbar spine, it may lead to cold abscess in the rectus sheath and the lower abdominal wall along the intercostal, ilioinguinal, and iliohypogastric nerves. Sometimes in the thigh along the psoas sheath. Psoas abscess can cause flexion deformity of the hip joint. In the cervical region, it can produce swellings in the posterior triangle of the neck and the axilla. In the thoracic, it can produce swellings, obstruction in the mediastinum and anterior chest wall. A diagnosis of tuberculosis or skeletal tuberculosis is by looking at the typical clinical presentations, various constitutional symptoms including weight loss, evidence of previous exposure to TB or concomitant visceral TB that is present, and taking advantage of various neuroimaging modalities including the MRI scan. A full blood count or a complete blood count, an ESR, will also help, along with a Mantoux test. Mantoux test may not be so relevant in an endemic area. The other tests which can also help are the ELISA test and, of course, the polymerase chain reaction or the PCR. However, the definitive diagnosis is by bone tissue or an abscess sample that are obtained for stain for AFB and isolating the organisms for culture, looking at the various antibiotic sensitivity and also the histopathological appearances. A CT-guided or ultrasound-guided needle biopsy or aspiration or even a surgical biopsy sometimes help us to obtain the samples for definitive diagnosis. A radiological investigation like in plain radiographs or X-ray is the initial investigation that is going to be performed. Now, for a radiolucent lesion to be present or to be apparent on the X-ray, almost 30% of the bone mineral loss should occur, which might be a bit late in the disease. A paradiscal type of lesion, the earliest radiographical feature are narrowing of the joint space or the disc space and indistinct paradiscal margin of the vertebral bodies. The disc space narrows, atrophy or prolapse into the vertebral body of the disc tissue. With further progression, there will be anterior wedging or collapse, resulting in varying degrees of kyphosis. These are typical radiographic or plain radiographic pictures of tuberculous spine, causing paradiscal lesion, causing decrease in disc space and destruction of the end plates. And the second picture shows the paraspinal abscesses along with partial destruction of the vertebrae. And the third picture also shows the paradiscal lesion with destruction of the vertebral body and disc space and some amount of kyphosis. At present, MRI is a gold standard in radiological imaging of tuberculous spine. Abnormal signal intensities appearing hypointense on T1 and hyperintense of T2 sequences can be picked up. There will be heterogeneous enhancement of the vertebral body. Characteristic findings of tuberculous spine include destruction of two adjacent vertebral bodies and opposing end plates, destruction of intervening disc. There could be vertebral body edema and characteristic occurrence of prevertebral, paravertebral, and epidural abscesses, which can be quite extensive. MRI can also pick up skipped lesions, which are common in around 4 to 10% of cases of tuberculosis spine. These are the typical MRI pictures of tuberculous spine, showing destruction of the paradiscal and vertebral body with epidural abscesses, and also showing a skipped lesion. Kumar in 1988 has classified the clinical radiological features of TB spine into 5 stages: pre-destructive, early destructive, mild, moderate, and severe kyphosis. Duration varying from less than 2 months, 2 to 4 months, 4 to 9 months, 6 to 24 months, and more than 24 months or 2 years. In the pre-antibiotic era, the management of spinal tuberculosis, or tuberculosis in general, were in TB sanatoriums like these, where patients were treated with bed rest, sunlight, and nutrition. With the invention of streptomycin, the first antibiotic used to treat TB, discovered in 1944, things began to take turn for better. In the present day, tuberculosis spine is treated by a multidisciplinary team which involves infectious disease experts, neuroradiologists, and of course the spine surgeons. Early detection and timely and judicial surgical intervention are the keystones for treatment of tuberculous spine. One of the key things to understand in spinal tuberculosis is that it is a medical disease, and anti-tuberculosis drugs, or ATT, have the main role in recovery and response of patients. Adequate early pharmacological treatment can prevent severe complications. A combination of rifampicin, isoniazid, ethambutol, and pyrazinamide for 2 months, followed by a combination of rifampicin and isoniazid for a period of 6, 9, 12, or 18 months, is the most frequent protocol that are being currently used for the treatment of spinal tuberculosis. When it comes to treatment of spinal tuberculosis, the middle path regime proposed by S.M. Toley has been widely used and with good results. In this regimen, patients are given anti-tuberculous drugs, along with frequent follow-up with radiological as well as hematological investigations. Gradual mobilization of these patients with the help of braces and surgical intervention was reserved to only a certain group of patients. Indications for surgery in spinal tuberculosis were reserved for these certain group of patients: when you need a tissue sampling, a biopsy when the diagnosis was in doubt, drainage of an abscess in the cervical spine causing difficulty in swallowing and breathing, drainage of a large paravertebral abscess, persistent neurological deficits in spite of ATT or worsening neurological deficits, recurrent neurological complications or presence of instability in spinal column, and in cases of severe kyphotic deformity. And when it comes to surgical management of tuberculous spine, there are different options that are available in the present day. Posterior decompression and fusion with bone autografts, anterior debridement, decompression and fusion with bone autografts, which used to be known as the Hong Kong operation, and with instrumentation the modified Hong Kong operation. The third one being the anterior debridement, decompression and fusion, followed by simultaneous or staged posterior fusion with instrumentation, or for the other way, which is a posterior fusion instrumentation followed by simultaneous or staged anterior debridement, decompression and fusion. When it comes to decision on which approach to use for surgical intervention, there are a few parameters that we need to take note of, including the age, presence of medical comorbidities, the location of the bony destruction, whether it's anterior and posterior or whether it is both, the density of the compressive lesion, whether it is pus or a solid extradural lesion, the bone stock of the patient, the number of segments that are involved, the degree of the kyphotic deformity, and the region of involvement, whether it is craniovertebral, cervicothoracic junction, thoracic-thoracolumbar junction, upper lumbar, or whether it is the quadraequina region. In general, the approaches used to be, if there was a stable anterior disease, was anterior debridement plus or minus stabilization. If there was an unstable along with kyphosis, anterior debridement with posterior stabilization. If it was an anterior disease with poor premorbid precluding an anterior approach, then it was a transpedicular debridement and posterior stabilization. But if it is a posterior disease, it was posterior decompression plus or minus stabilization. The recent trends in the last 2 decades or so has been toward an all posterior, or everything from the back, global reconstruction of the spine, especially in the thoracic and lumbar spine. There are newer techniques, including newer minimally invasive techniques like endoscopic spine surgery, that are being used for drainage, decompression, and stabilization, reducing the collateral damage that are caused by surgery and improving patient outcomes at the same time. Chemotherapy is still the key, with 85 to 95% of patients showing improved outcome, even when patients present with deformity and neurological deficits. However, increasing co-infection with HIV, multi-drug resistance, global migration are now the major challenges for an effective treatment and control of tuberculosis. I sincerely hope this presentation was useful to you. Thank you for watching, and see you again soon with some more videos in my spine world.